This is Doctor Talks, real talk from real doctors on the issues that matter to you most.
Today, we're joined by Dr. Tro, who is, one of my favorite guys in this space. Like, super passionate about what he does and really cuts through the bull, in a way like nobody else. And I really respect that because sometimes you just got to hear it blunt. And the thing is that he's, has a great backstory, which we'll get into, but really had a huge amount of success to treating patients because that's where the rubber hits the road. And this is always one of my pet peeves too, and I'm sure you agree, Tro, is that you get all these guys who are like academics or, they say, oh, it's all about cutting calories. Look, I proved it with my energy balance equation. Therefore, it should work. And if it doesn't work, it's your own damn fault, right? And it's like putting the blame on patients. And you know what it's like to be on that side of things. And you know what it's like to be, in medical school and learning about, hey, it's all about calories, all about calories. But this is where it's like you got to treat the patients because when stuff doesn't work, you have to say it doesn't work and find something that does. That's being a doctor. It's not just repeating the same old stuff that we were taught that everybody knew didn't work. And that's where I really love what you've done with your weight loss clinic, helping, hundreds or thousands of people, your results, which I'd love for you to go into, which you've published, just jaw dropping, right? And of course, weight loss is just such a huge part of longevity and good health. So, Ro, why don't you take us through your story, like when you were in medical school and when you were struggling with your own weight problems, because I think that's really important.
Yeah, well, thanks, Jason. First of all, you are an inspiration, actually. The plain talking, blunt, say it how it is. I definitely learned from a good mentor and somebody who's always been good to me and gracious to me. I've read all your books. I still recommend your books to this day. And I think, having the courage and the vision to execute on the things that you've done, I think that it gives us a leg to stand on. So, and there's so many that came before both of us. So, going back to Atkins and Noakes and Fedke and Nina Teicholz and Eric Westman. But yeah, so I appreciate, I love being here. Happy to be here. My own story starts really when I started to experience obesity at age 4. I remember going to a supermarket and running away from my mom and running to the ice cream aisle and literally opening up boxes of ice cream and eating them as a 4-year-old, right? So in the middle of the supermarket, that's where my journey started. I was unknowingly had all the quote unquote obesity genes. And I also had a thyroid issue that would go basically undiagnosed. So I had all of the quote unquote causes of obesity, genetics and a thyroid issue. So at age 13, I was the current weight I am now, which is around 200 pounds. Sat in a office with a doctor who took care of my family, and he made me wait in the waiting room for 2 hours and then put me on a scale and said, I'm fat like my family and go count calories, right? This is literally what he told me. And he didn't know this. Like I have a like nearly photo, at least when it comes to numbers, like a nearly photographic memory. And I had memorized every nutrition label on every cereal box. I knew the calories of everything, right? It wasn't the knowledge of calories that I needed at the time. But that was the moment where I was like, I'm going to be a doctor. It was this anger that I had at this guy who was like, go learn about calories. I already knew it. So that's when my sort of origin story started. Of course, you mentioned going to medical school, gaining 10 pounds a year, going to residency, getting 10 pounds a year, board certified in internal medicine, chief resident, and ultimately getting obesity board certification. And I was a 350-pound doctor. And same thing in the Yale system. I'm told go and, why don't you count your calories? Cardiologists would say you should lower your fat. The endocrinologist would say you should be in energy balance. And nobody once said, well, let's figure out what's driving your eating. Are you hungry? Nobody once said that. Nobody once said, do you understand what foods satiate you? What foods keep you full? Do you understand, that fasting may actually decrease your hunger, right? And nobody said that. So ultimately, it didn't come from the medical community, my inspiration to sort of learn more. It came from my wife who said, are you going to be alive? Can you go figure this out? You scored on the 90th percentile on your board exam. You're not dumb. You're a smart doctor. You're the chief resident. Go figure this out. And then I turned to literature, 300 diet books. I read through 1,000 maybe original articles. And what I found out was a lot of what you've been talking about for years, which is a lot of our nutrition and medical information is co-opted by industry. And this has come out over the last 10 years through the Global Energy Balance Network and the conflicts they have. The JAMA article you posted about very recently, talking about the $1 billion of conflicts. So anyway, but you can weed through that if you actually read the literature. And when you read the literature, it's just low carb and intermittent fasting are powerful. And in fact, they're more powerful than low fat approaches, and they're even more powerful than calorie counting approaches. So if you look at the interventional data, calorie counting is literally the worst way you can approach weight loss. Then it's sort of low fat, and the optimal is really, a low carb and intermittent fasting approach in my interpretation of literature, and very much so for metabolic syndrome. So that was it. I had never eaten a steak at that point. I had never cooked a steak. I went through stints of being, very strict sort of calorie counting and even being vegetarian for a bit. And what I found was that for me, addressing hunger and addressing the metabolic syndrome was critical. And I applied those principles to a practice. So 7 years ago, I started a nationwide practice. Well, we started in New York, but we've since expanded to 50 states. There's 3 doctors, 4 health coaches, a personal trainer, and we leverage remote monitoring using, continuous blood glucose monitors, ketone meters, body composition scales, blood pressure cuffs, even Holter monitors, sleep studies. We can all do this remotely. We have a nationwide network of imaging centers to get calcium scores and to get labs done. And we've helped 2,000 patients lose, and get this, you'd be proud about this, almost 100,000 pounds in our clinic. And my mission is clear: to be the medical practice that I didn't have, and to actually make a difference. And we've published our results, as you mentioned, and we have 2-year results in submission with 15.5% weight loss at 2 years in a large cohort of patients. And this is without, we're weight loss medication neutral, meaning we do not prescribe them. We do not prescribe as many as we discontinue. So meaning that our weight loss results are literally world-class, in my opinion, and I'm biased. And we've also published our...
Well, I think it's pretty clear, right? 15.5%. I mean, that's better than almost anything out there, right? So it's not your bias. It speaks for itself. I mean, that's crazy.
And we published in our original cohort, we calculated the 10-year, atherosclerotic cardiovascular risk index on our cohort of patients before and after. And before our program, they came in at about a 9.5% 10-year cardiovascular risk. And after our program, the risk was, just under 6, about 5.75%, meaning we reduced the 10-year cardiovascular risk using the most widely accepted AHA, ACC cardiovascular risk estimation tool. we reduced the risk of cardiovascular disease by 44% in this cohort. And so when we published this data, we also published the cost savings. We also published the cost savings, which was about anywhere from $2,000 to $4,000 per year in just prescription costs. So depending on the cohort, the very sick cohorts, up to $4,000 a year, we're saving in deep prescription costs, and in the sort of less sick cohorts, about $2,000 per year. And in those papers, one was published and one is submitted, so we're pending publication. So yeah, I've lost 150 pounds and kept it off almost a decade now. And I'm applying the principles that, I've learned from all the luminaries, including yourself. We published even and I'm going to pause here after this, so many of the endocrinologists out there were so doubtful of the results. We published had a med student sort of seeing what's going on in our clinic. She's like, I have to publish this. We showed that we lowered A1C in a cohort of patients when she was just visiting our clinic from an A1C of average, 11.5 to 6.5 with just low carb and intermittent fasting. So that's my goal, is to basically be the practice I wish I had. It's to make people like you and Eric Westman and Nina Teicholz and, Tim Noakes all proud, and in a way that you can, say that, exemplify all the principles that we all talk about. So that's the goal.
Yeah, that's amazing. It's just crazy good, these results. Like, I can't emphasize enough, like lowering your risk of a heart attack or stroke by like 44%. Virtually no intervention or medicine can actually do that, right? 15.5% of weight loss. Maybe you get that with super high doses of Ozempic and stuff, right? But with a lot of side effects. But those are results that are just off the charts amazing, right? And the thing is, it comes back to sort of the principles. And this is where I think I've always felt a little bit betrayed by the sort of academic sort of medical school teaching sort of thing, because it's all about calories, as you said. And yet, everybody sort of says, oh, well, you just have to count calories. That's all it is. But if you look at the actual data, there's actually 0 long-term trials. And they've been done, right? The Women's Health Initiative, there's tons of trials that have said, oh, cut 500 calories. People cut 500 calories in a low-fat diet, they eat less fat and so on, and they don't lose weight. So it's very clear that just focusing in on calories, and of course the traditional strategy was cutting fat, is actually guaranteed to fail. That's what the evidence shows. But more than that, that's what the real life evidence shows. We've all done it and it doesn't work. So why do we keep saying it's true, it's true, it's true? And this is what you've always been getting at, which is, we're not saying, that it's like calories is the wrong thing to look at. You have to look at what's driving the calories, right? You have to get to that deeper level of understanding, right? It's sort of like I always say about alcohol. Well, you can say alcoholism is alcohol in minus alcohol out, right? That's obvious. So it's all about alcohol. Well, if you're suffering from post-traumatic stress disorder, which is causing you to drink alcohol, you can't just say, just drink less alcohol. That's the stupidest advice you can hear. But yet, when you apply, you have to treat the PTSD. If you apply the exact same logic to calories, if you have, depression, ultra-processed foods, refined carbohydrates, which is driving your calories because they're not making you full. Nobody ever says, eat fewer carbs, eat less processed foods. They just say, it's all about calories, but it's the exact same flawed logic. And that's what always gets to me. It's like how bad that one, how bad the advice is, but two, also how bad the logic is behind that advice. It actually makes zero sense. Like it makes no sense at all, the strategies that we use. So what's the core, you've obviously had great success with yourself, which is amazing, and also with your patients. So what are the sort of core principles that you use in your clinic? Because you're not the only one who's had success. Dr. David Unwin has had tremendous success with using the same principles. So maybe what are those key principles that you use in your clinic?
Yeah, so I want to emphasize that I'm going to talk about that, and Dr. David Unwin is another mentor of mine. We worked together on this paper that's submitted, which I was, so glad that he, was able to serve as a mentor on that paper and guide it, because he truly is a champion, just like yourself. But let's come back to this, the silliness of calories. I think, you brought up the example of alcohol. Like, to think about it this way, I think, is the easiest way. It's not just the calories make you eat more calories, which they absolutely do. When we have calories from carbohydrates, even calorie controlled, you will develop metabolic syndrome, right? And we know this, calorie controlled, you will develop fatty liver, calorie controlled. You will have glycemic excursions, which make people gain weight and get hungrier, right? So, and this is calorie controlled data. So the idea that the calories can make you want more calories, I think that's also, now becoming well understood and more understood, particularly through the lens of those blood sugar roller coasters. When your brain is seeing hypoglycemia in the setting of high insulin, it's like on fire for food. And everybody knows it. You just have, some Chinese food, and then 3 hours later, you're loving the leftovers. And the reason why you love the leftovers is that blood sugar vacuum your brain is seeing. And the same is true with cold pizza. Everybody loves cold pizza 3 or 4 hours later for a reason, right? Our brain has been primed to eat more, and our body is preferentially storing energy. But then the other side is true, and your issue with alcohol, like the way you brought it up, I think is the case in point. If you had 1,000 calories of steak, an hour later, 2 hours later, 3 hours later, you may be going on a hike. You may be the next day, certainly you feel great, right? If you had 1,000 calories of alcohol, how much energy expenditure will that lead to? I mean, you'd be out cold, and the next day you're hungover, not interested in going hiking, right? So the calories not only determine the calories in, they also determine the calories out. And I think this is the problem with calories. When you focus on calories, it's like trying to get to the answer without doing the work, right? And the work is, how do these calories affect your body? Pay attention to that and course correct, right? And then, you hinted at the sort of, this budgeting approach to obesity, when really it's needs comprehensive care, which is absolutely correct, and you mentioned the pillars, which I think ties into this idea of comprehensive care. The baseline is lowering sugar, processed carbohydrates, and processed fats. And if you do that, 70% of people don't need me. They can just download our free app and get that help, and that's all there. And then they can, do that on their own, or they can go to page 4, which is also free from Dr. Westman, or they can just pick up a $5, copy of your book, and they can, the obesity code, and they can get that. And then, once the hunger subsides, practicing that non-hunger, right, and practicing that, satiation, that's basically, hey, why don't you quit snacking and intermittent fast, do time restriction, right? And that's like the easiest next logical step. And the people who run clinical trials in metabolic wards, they purposely design their trials to get around this. If a trial makes you naturally not hungry, right, what's a way to counteract that? We'll bring them to a mess hall, give them 3 meals and 2 snacks, right? That's how you equalize. And our good friends at the NIH who've done these trials, they know this. They're not silly, like they know what they're doing. So the first order principle is actually nourish your body with things that will make you full for a long time. And then when you're full, practice not eating, stop snacking, pull back your last meal, delay your first meal a little bit, and that's the process of intermittent fasting. And I think, the average American, you've said this, is eating 16 hours a day. We need to make that fasting at least 16 to 18 hours. Most of the patients in my clinic are eating in a 4-hour window, or less. And then, then I think there's other pillars that we all sort of agree upon. Movement is very critical, excellent sleep. And this is, absolutely a huge miss in our entire population. Just 1.5 hours extra of sleep. Again, going back to how faulty calories are. If you sleep 1.5 hours more a day, you will naturally eat 300 calories less a day. If you are awake 1.5 hours more, you will naturally eat 300 calories more per day, and your ghrelin will be higher, right? Your fasting ghrelin will be higher. The hormones that make you hungry, these hunger hormones, are going to be off the charts. So not only, are you miserable, you're also hungry and eating more, right? So again, sleep is another chink in the calories armor. It makes you eat less. It makes the calories in go down naturally. So sleep is another important pillar to pay attention to. And then, for the patients with really severe autoimmune disease or severe insulin resistance, that's when we leverage sort of extended fasts. And, we grade those fasts. We start with baby steps, and we learned this from you in your clinic. Maybe one 36 to 48-hour fast a week, and then we titrate up depending on whatever is needed. But most people can just heal with time restriction. In special cases or very severe cases, you can progress to prolonged fasting, and particularly with autoimmune disease. And I've seen, particularly with gut issues, I've had, great success. I think the MMA fighter who had bad ulcerative colitis often credits you for introducing him to prolonged fasts and healing his gut. Yeah, so those are the basic pillars we use in our clinic. And the other, most critical, piece is, well, what are the things that prevent people, if they experience a way of eating that brings them health, well, what are the things that takes them away from what they know is giving them health, what they know they should be doing? And that's really addressing mental health, stress, and food addiction. And I think it's not a nutritional pillar. It's more, I'd say, in the mental health paradigm, but helping our patients manage stress, manage their mental health, and manage any food addiction and food relationship issues, I think is a key focus in our practice. And I really think I'd love to see the world start to embrace that more. And one of the big leaders in that area is actually the Unwin family.
Yeah, that's super important. Like I always think about food addiction because it's actually coming up on a lot of people's radars and so on, in the context also of ultra processed foods, right? Because they're sort of engineered to be highly addictive as well, right? So it's getting a lot more traction now. But I always think about this paradigm that food addiction, which is super interesting to me because it's like you have food addictions, which, addictions are things are bad for you, but you do it anyway, right? Like smoking or whatever. If you're addicted, you know it's bad for you, you just do it anyway. But if you have food addictions, and that can happen, it causes you to sort of eat a lot of stuff you shouldn't eat, like, Cheetos or whatever. And that's what's driving your calories. So it's always like, well, if you know that the food addiction is driving, or if it's the emotional eating, or if it's the depression, which is driving your calories in, calories out, which is driving your weight gain, how is it that people are so stupid as to say, just count your calories? You're so stupid, I always think, because it's the food addiction which is driving that. You got to deal with the addiction. Why don't you say to a heroin addict, just take less heroin? You're welcome. I just solved your addiction problem. But yet it's the same logic. And that's what boggles my mind these days, is how stupid the whole thing is, and how you can, how fasting can, for example, break some of those addictions, gut issues, leaky gut, and so on. I mean, prolonged fasting is actually a very interesting topic, just because I don't talk about it a lot, because when you talk about it too much online, people will you don't know who's going to take your advice and go way overboard, who shouldn't be doing it, right? So if it's in a medical practice, it's different. But there's actually just so much data and, coming out there now. And a lot of the data looks at these longer fasts, and a lot of them are not full water fasts. Because I know Al Nutra has been doing a lot of data, but it's super interesting. I'm telling you, the some of the stuff they come out with, some of the results are just sort of mind-boggling. And clinical practice, like I have people, like you mentioned, the MMA fighter Georges St-Pierre, who completely basically turned around his colitis. I have tons of people who are talking about all these inflammatory autoimmune conditions that actually disappear. And there's data on these longer fasts because, again, the body's saying, hey, you know what? Nothing's coming in. We need to make sure that we're not, keeping cells around that have no purpose. So if you have an overimmune immune system, that might, for example, start to bring those down and reduce some of that autoimmunity, that sort of inflammation. So there's not a lot of data because they haven't done the studies, but it's just interesting because you hear a lot of anecdotal studies. Like we hear tons of it because we do, with the fasting method, we have a lot of people who do it, but we have tons of people, especially like Hashimoto's thyroiditis, right? I can't find any scientific data because nobody likes to look at these things. They like to treat it with drugs. But I hear tons of people who are like, oh man, my Hashimoto's just went away, which is a type of autoimmune disease, of course. So interesting.
I can add a little clarity there. There is actually data on, so I've been fascinated with this topic really ever since hearing some of the stories from your clinic and people who've credited a lot of these sort of miraculous changes. There is actually a interventional study comparing a low fat to a low carb diet in Hashimoto's thyroiditis. And I want to say it was almost 100 patients with MRI findings and antibodies pre and post. And lo and behold, what did they find? Low carb diets actually decreased antibodies statistically significantly higher than the high carb diets, and they decreased edema in the thyroid on an MRI. So, and what do the people on low carb diets do? As we know, they spontaneously eat less frequently, and typically, so it's basically saying low carb and time restricted eating is a antidote to Hashimoto's. It's an early study, right? But it's very convincing. And there's been some other studies with people doing carnivore and OMAD who reversed, in a case series, who reversed their inflammatory bowel disease. And this is biopsy proven, reversals in their bowel. And the question I've had is, is there something in our sugar and grains? What's the biochemical? Is there some exposure that's with the sugar and the grains that, maybe a contaminant, maybe a pesticide? Is it a combination of that and the known autophagy benefits that you commented on? Is it also that, and knowing that these ketotic diets, decrease interleukin-6, decrease TNF alpha, is it a combination of all these? I don't think we know, but these are pretty miraculous results. And that trial was just published. It was a trial in China, maybe 3 months ago or 6 months ago, which is absolutely fascinating. The first study I've seen to have an impact on autoimmune disease ever. An interventional trial.
And same with a tweet you sent out. So you turned me on to this other study in the Interfast study, which to me was
that paper.
you tweeted it out.
Yeah,
I have to look at the full paper still because I can't get it. But it's like it was. So this study came out a month ago or something like that. You tweeted it out, so I listened to it, and it was mind blowing. Like to me, it was completely mind blowing because you know how people always say, "Oh, fasting burns your muscle." I'm always like, "No, it doesn't." But what was interesting was in this study, they randomized people. It was a small study, I granted that, but they randomized people to after a heart attack, a serious heart attack, because it's the elevation MI, right? STEMI, to intermittent fasting versus sort of regular diet. And the people who did the fasting, I think 3 times as many had an improved left ventricular ejection fraction, which is incredibly important to your overall survival in the future for your heart function. It means your heart is actually functioning better, your muscle. And that was just mind blowing to me because that was a huge, huge improvement in a completely different, because you know how medicine is, right? They go into these, oh, you should thin the blood. So then, you get 10 drug companies who are like, oh, let's find other ways to thin the blood, or cholesterol. Oh, let's find other ways to do cholesterol. But this is a completely sort of paradigm changing thing that, hey, this intervention, which is intermittent fasting, it has a lot of different ways it might help. It might help with insulin sensitivity. It might help with autophagy. It might help with healing. It might help with immunity. It might help with inflammation. So many different ways. We don't know which way, but the point is that there's potentially a huge, massive benefit here that we're not using for our patients, right? And I agree with you. A lot of these things, people look at, a lot of academics too. They drive me crazy, I tell you. But they look at it the wrong way because they'll say something like, oh, well, for say Hashimoto's or inflammatory bowel disease, there's no evidence that fasting helps, so therefore you shouldn't do it. And I was thinking, are you stupid? Because that's completely the wrong way to look at it as a patient. As a patient, you should be saying, what's the downside if I do intermittent fasting? I might get hungry for a little while, maybe, maybe not, but I might lose some weight. But really, it's not that, as long as you have adequate stores of body fat, there's really very little risk as long as you do it intelligently and you get help and get medical supervision, such as at your clinic. What's the potential benefit? Hey, I might just cure the whole damn thing, or my heart might be so much better for it, or I might reverse my diabetes. So the risk benefit is like massively weighted towards doing an intervention such as fasting because the risk is so low. And people have been fasting for thousands of years at least. But the potential benefit, whether it's inflammatory bowel disease, thyroiditis, or heart function, is massive, like on a scale that's beyond what you can imagine, even from your own results, right? I mean, you showed that, right, Tro? Reversing diabetes, right, from 11.5 to 6.5. That's insane. Like, no drug will do that for you. You might need to take 4 drugs to do that for you, right? So it's like people are always like, oh, there's no benefit. I'm like, you guys need to treat some patients because you're not doing your patients any good. And if you practice clinical medicine, you'd know that. Because the way to look at it is as a patient. If this was my brother, sister, father, mother, would I tell them to do that? 100% yes, 110% yes. You should try it. If it does you no good, don't do it anymore. If you can't do it, find a way to do it so you still get the benefits, right? Whether you do sort of shorter fast or longer fast or get some help with the fast. We talked about training wheels for the fasting, at the fasting method. So whatever it is, but that's the way to look at it. And that's the way you're going to actually help people, which is why I think, which is why I love what you're doing, which is really getting out there and helping people, because that's why, people can't touch you, Tro, because you get the results. Like people are coming to you because you're telling them the truth and they know it. Like you go to these calorie counting doctors and they're like, that stuff doesn't work. Like you knew it as a doctor. I knew as a doctor. So why doesn't anybody tell them?
I think it's important, we're here, this is largely a fasting talk. That InnerFast MI trial was very interesting. It actually came out earlier this year, and it was a single center study. They did it in 2020 to 2022. I think it was 50 patients, and they did the intent to treat. They pre-registered intent to treat. They published a protocol in BMJ, like maybe in 2022. And then they published this paper in, I think it was Circulation. And the interesting thing, what they did was they separated the arms into sort of eat calorie controlled post MI, which is a low fat diet. And the other group was, do a intermittent fasting, it was 18-6, which was what they were using. So 18 hours fasted, 6 hours eating. And then they followed up at 4 weeks, at 3 months, and at 6 months, looking at the ejection fraction of the heart, which is how good that heart is pumping at 4 weeks, at 3 months and at 6 months. And at every single time point, which is kind of crazy, the intermittent fasting group had a higher ejection fraction when they started at the same, right? Everything was randomized. It was, the EFs were basically the heart pump was equally impaired. On average, the intermittent fasting group improved about 20, almost 20 points. EF improved 20. And just for that listener, the average improvement is like somewhere between 5 and 10, right? So this was significantly higher improvement. So, which is, fascinating. We kind of expected this from the, pharmacology data, right? The SGLT2 data, right? Supposing that the mechanism is the same, lowering the glucose, lowering the insulin, and making some ketones. But this was stellar. It was a small study, but again, post MI, fasting should not be withheld. We have, eating, some eating disorder data, which is a big concern, when there's eating disorders. We published some data actually that intermittent fasting and low carb improves food addiction symptoms. And there's some data now with the carnivore diet and in anorexia, which is also a little bit controversial. And then, we've talked about intermittent fasting in other states, particularly it's being looked at in certain cancers like glioblastoma, ovarian cancer. And at the least, I think, the important thing is being mindful that these patients are vulnerable and you don't want them to go and just not eat anything. You want them to get nourished. So yes, I think the average doctor that's spending 7 minutes shouldn't just go and recommend fasting, but in a comprehensive clinic that's really doing a good job, I think we are moving away from this idea that fasting shouldn't be done to actually, there's a lot more therapeutic potential than we first realized. And actually, we shouldn't have blanket told everybody, with cancer to go eat ice cream and bonbons and do whatever you want. Maybe that wasn't the best idea. So I think these trials that you talked about, more and more are coming out. Again, it's very early, but it's enough that the guidelines should include intermittent fasting and low carb as something that shouldn't be avoided. It should not be contraindicated. It's not contraindicated. It just needs to be done responsibly and carefully. I think the worst thing we all could do is, take somebody who has intense weight stigma, intense anxiety, food avoidant behavior, very low BMI, and maybe emphasize fasting in that person. That's a vulnerable person. And just about anybody else, I think we can get their feet wet with intermittent fasting safely, especially if you're a doctor listening to this or a dietitian listening to this, you can safely implement these into your practice right now. And in fact, we've been doing this for 7 years and, we're publishing the results. David Unwin, as you mentioned, called upon us to publish our, clinical data, our observational data, and that's what we're doing. And the results are stellar. So nobody's going to run no pharma company is coming to sponsor a double-blinded, I don't know how you double-blind a fasting trial, but, nobody's coming to do a huge trial with fasting. Even getting these 50 patient studies done is a miracle. So these hints of data that are showing success in Hashimoto's, showing success in MI, showing success in diabetes, these are enough for the average dietitian and the average, physician to start promoting these in practice, especially if the nonsense calories recommendation didn't work. If your blanket, recommendation to eat 2,000 calories didn't work, as Dr. Jason Fung says, stop being stupid and, try a different approach. It may, you may be pleasantly surprised.
The trials that are coming out now are sort of mind-blowingly good because, the InterFast MI trial was that, but they also had an InterFast, which was a diabetes remission trial. And it was like close to 50% of those people went into a drug-free remission, which is sort of insane. Again, it's like results so good that they're practically unbelievable. They're like 10 times better what you get with it than what you get with anything else. The early fasting trials, I remember this because this was sort of big a few years ago, was they do these fasting trials. And this is, again, where you have people who have no idea what they're doing clinically trying to run a trial. And they'd be like, oh, on one day, we're going to have you eat, 500 calories, but then the next day, we're going to have you eat like double your calories. And I'm like, why the hell would you want that to happen? So then these people are forcing themselves to eat. Meanwhile, they're way overweight and their sugars are high. I'm like, what the hell? Like, what the hell is that? And then they're like, oh, well, there's no benefits. Fasting doesn't work, right? So about 4 or 5 years ago, we had a rash of these trials. I was like, oh, fasting doesn't work. And it's like, now that you actually have a bunch of trials coming out of everywhere, really, that are just showing the benefits of this approach. And now, thankfully, we're sort of getting past that point. But, I just emphasize that all the trials are coming out now, 2023, 2024. They're almost all like not just positive, but like sort of super mind-blowingly positive about the benefits that you can get. And it comes down to the fact that, like, you look at some of these diseases, obesity, we know, is a high insulin state. We know people who are overweight have a lot of insulin. Well, insulin tells your body to store body fat. That's its job. If you have too much of it, you need to bring it down, which low carb and fasting does. If you have diabetes, we know your insulin levels are sky high. Well, if it's sky high, then you should bring it down. Like, that's not that hard to understand. What's going to do that? Low carb, intermittent fasting. Okay, that's not too hard to understand. You have certain cancers. Again, cancers love insulin. Some of these cancers have, 6, 7, 8 times the amount of insulin receptors compared to a normal cell. They love it. What is it doing? It's dragging all the glucose into the cancer cell and letting it grow. Well, if you have low insulin, it's going to affect those cancer cells more than others. So it's like there's good reasons why these things might work. And again, maybe, if you're a purist, you'll say, oh, let's wait 15 years until all the studies are done and everybody agrees. But you know what? If you're a patient, that 15 years could be too late for you, like much too late. I mean, 10-year risk of heart disease. Like, I'd rather bring it down by 44% than risk having a heart attack, in the next 10 years, stroke, these terrible diseases. And if it does happen, I want an intervention that keeps my heart muscle pumping well. So, so much happening right now. And then, thanks so much, Tro, for being here. And thanks so much for contributing your expertise. And I love, again, I love your passion online. I think it's the best. Like, your tweets and stuff, they're the best because yes, they get a rise out of people, but it makes people stop and think and listen, right? And that's, to me, I think the greatest thing you're doing out there. You're doing so much good. And you're challenging that orthodoxy, and they need more people like you, like real doctors who have, like, really walked the walk. It's amazing. Thank you so much, Tro.
Yeah, it's absolute pleasure. And one parting, I guess, word is, we're trying to make those doctors now with the Society of Metabolic Health Practitioners, a not-for-profit that's looking to train doctors and coaches and dietitian on the power of metabolic health and do it ethically and do it responsibly and evidence-based. So my hope is it's not just, Dr. Fung and Dr. Noakes and Dr. Fetke and Dr. Teicholz and Dr. Westman. And, we train an army of doctors and coaches to, in a way that's not for profit and truly philanthropic to change this, because, our metabolic health crisis is enormous, with a 40% obesity rate, a diabetes rate that's out of control, and the expense of the drugs, insulin and the pharmaceuticals are going to bankrupt us. And we really need to drive it home that it's not just, a moral failure or discipline issue. This is, an epidemic hitting our pediatric population. I describe myself at 4. By age 8, I was going to Weight Watchers with my mom, and I was already obese, and I had gynecomastia and everything. We have a pediatric obesity epidemic right now, fatty liver, diabetes. And so finding these solutions, you're absolutely right. The trials are there. We no longer need to wait, right? We should not wait. We know that the orthodoxy in medicine won't change. We have a lot of evidence around that. around the regulatory capture in our medical industry, including the AMA and the AFP and the American Academy of Pediatrics, who I wrote an editorial about, because their guidelines call for 25 blood tests and an imaging study to safely lower the carbohydrates of an adolescent with metabolic disease. That is what their guidelines say. And yet their guidelines say, you should not withhold bariatric surgery or Ozempic, and it does not talk about doing any blood tests or any imaging for those modalities. So we are facing, why am I bringing this up? I'm not to single out the pediatric organizations or any organizations, but the monumental effort it'll take to change these organizations may take decades. We know that the original research that you and I are talking about will take at least 10 years to find their way into traditional guidelines, maybe longer. And we are facing such an unprecedented calamity in our populations with the dual pandemics of obesity and diabetes that we can't wait. So I appreciate you having me on, giving me the time to talk about the importance of this. And we have to do something. And you're absolutely right. If it was my mom or dad or brother or sister, what would we tell them to do? Start lowering your carbohydrates, stick to real foods. When you're not hungry, don't eat. And once in a while, do an extended fast in a responsible way. So thank you for having me.
Yeah, thank you so much. And yeah, again, you can find Tro on his podcast, the Low Carb MD Podcast, which is great. And also check out his Twitter feed and, his medical weight loss. So thanks so much, Tro.
Thank you for tuning in to Dr. Talks. We hope today's episode has enlightened and inspired you on your path to optimal health. Each day is a new opportunity to make choices that empower your well-being. For more insights and strategies, subscribe to our podcast and visit our website, www.drtalks.com. Stay connected, stay healthy, and join us next time on Dr. Talks, real talks from real doctors on the issues that matter to you most.